and welcome to Talks with Docs from the Lancaster County Medical Society. I'm Dr. Dale Michels. We're pleased today to be joined by Dr. Les Spry, who's a nephrologist here in Lincoln, and we're going to talk today about hypertension or high blood pressure and what it means. So Les, it's going to be good to talk about this. We have a lot of patients with hypertension. I think you and I figured out 2/3 to maybe even half the population may have high blood pressure. One time, one of our physician friends told me if we put something in the water so everybody who didn't have their blood pressure under control would feel bad, we could take better care of them because they'd come see us. Because hypertension is largely kind of a silent illness.
It absolutely is. We estimate that there's probably somewhere between 60 and 100 million folks out there who have high blood pressure, and some of the most recent data suggests that only about 60% of them are even aware of it. And that of those 60% that are aware of it, about half have their blood pressure controlled. So we've got a huge effort that needs to be done to be able to close some of those gaps that have been identified in some of the epidemiology of high blood pressure.
Well, and I think it's important for people to realize that most people with hypertension or high blood pressure don't really know that they have it. There isn't really any symptoms, at least in most of my patients, until it gets really, really high, and then they may not feel so good. But most people don't feel bad.
Yeah, because a lot of people think that just because they're anxious, they may have high blood pressure, and that is not true. Anxiety or being nervous about something does not translate into hypertension. I like to tell folks that while anxiety and nervousness, if you will, can make blood pressure control difficult, high blood pressure is not the result of anxiety and nerves. High blood pressure is a disease. High blood pressure is something that you have to be treated for, and it has to be recognized that it is actually a disease. It is not something that is voluntary, and if you think you can control your blood pressure, then perhaps you don't have high blood pressure. I have people who tell me that they can meditate their blood pressure down, and in certain cases they can, but then what I do is hang a 24-hour blood pressure monitor on them, and I show them at night that perhaps their blood pressure isn't as controlled as they think it is.
And of course we know that oftentimes patients' blood pressure is a little higher in the morning, and that's a little more of interesting. You'd think after a good night's sleep it would be lower, but it really is. It gets higher in the morning, and then they may not feel any different again, but it is a little higher.
Yeah, it's called morning acceleration, and actually that's a phenomenon of high blood pressure. There are two known phenomenons of people who have high blood pressure, and that is the blood pressures in most folks who have hypertension will be highest in the morning, and then it will tend to drop off as the day goes on. The second thing that'll happen is that while they sleep, their blood pressure does go down, and that's called dipping, if you will. That's the high blood pressure term that's applied to that. And people who are severely hypertension, or who have severe hypertension or high blood pressure, do not show dipping. They do not lower their blood pressure as they sleep, and so we think that that's part of the disease. In other words, the blood vessels inside of your body are having to withstand those pressures continuously for prolonged periods of time to the point that damage is done to the organ systems that we talk about. The 4 organ systems that are damaged as a result of that continuous pressure are the eyes. That's why the doctor looks in your eyes when you come in for your blood pressure checks. They make sure that there's what kind of high blood pressure changes are back there. Strokes, obviously. Those things are the bad things that happen inside of your brain as a result of high blood pressure. The heart sees all these pressures, and the heart becomes thickened and enlarged as a result of high blood pressure. And finally, the kidneys, my area, they become damaged with ongoing high blood pressure. So all of the blood vessels inside of your body experience that kind of pressure, and if that becomes more continuous, especially morning acceleration and that lack of dipping at nighttime, that continuous high blood pressure results in damage to those organ systems.
Well, a lot of my patients talk about white coat hypertension. They keep telling me that their blood pressure is only high when they come to my office, and I don't think I'm that threatening, but be that as it may, is that a problem? It does seem, in some people, it does seem to be elevated when they have to come see us.
About 15% of those folks who show up in your office will have white coat hypertension. That's the numbers that are out there, and we initially thought that perhaps white coat hypertension was still hypertension. And now with some of the more sophisticated ways that we have of measuring that, as I mentioned, we have a 24-hour ambulatory blood pressure monitor that we can send patients home with, and we can look at their blood pressure at home. And if their blood pressure is truly normal at home, and believe me, I've read some of these monitor reports, and the blood pressure when you hang it in the office, when you put it on in the office, it's very high. As soon as they walk out to their car, within 30 minutes, you can see this monitor blood pressure be normal. And then as soon as they're getting ready to walk back in my office, the blood pressure goes right back up again. And it's rather a striking phenomenon. What we've learned from those kinds of, and also the other thing you can do, and the cheaper thing to do sometimes, is just to take your blood pressure at home, as long as you don't get anxious about taking your own blood pressure. But if you can show me that your blood pressure is normal at home, then what the studies tell us is that those kinds of folks are not at any greater risk of those organ damage that we talked about. They're not at any greater risk than the general population.
Okay.
Whereas if you, let's take the opposite that occurs, and in about 5% of the population actually has the kind of high blood pressure that only manifests at home. In other words, that's pretty rare, but there is a situation that occurs where patients feel bad at home and they tell me their blood pressure is high, and then they get in the office, it's normal. And again, we use our ambulatory blood pressure monitor to show that. And if that's the case, that is true hypertension. In other words, being able to show that your blood pressure is high at home is a serious illness, and those translate into organ damage just like other kinds of high blood pressure.
Okay. Well, there are two numbers with blood pressure, and obviously everybody knows the numbers. Sometimes they get them confused, and I get somebody who comes in at 190/40, but realistically it usually goes the other way around. So let's talk a little bit about what's a normal blood pressure, or should be a normal blood pressure for most of our patients.
A normal blood pressure is 130/80 or less, okay? And that is normal. Now there's a spread though, so we have a spread between 140 on the top number, and by the way, let's just define the numbers. So the top number, that's the pressure that's generated every time your heart beats. So the heart beats, generates a pressure, and that's the top number that we get off. When the heart relaxes, that's the blood vessel, that's the pressure that remains in your blood vessels as you're resting in between heartbeats. We call that the diastolic pressure. And so the systolic pressure, the normal for that is less than 130. Diastolic pressure is less than 80. However, we consider high blood pressure to be greater than 140/90. So you see there's a little spread.
Yes, fudge factor
There's a little spread there. We call that, it's been called in the past prehypertension, or it's also been called borderline hypertension. And both of those terms apply. And what we recommend in that situation is that you should monitor that blood pressure carefully, and you should exercise regularly, low salt diet, DASH diet. We'll talk about that in a bit. But those are the kind of things that are non-pharmacologic management is what it's called, meaning we don't treat it with drugs, but we treat it with healthy activities that we hope that I know you teach your patients. If you have a blood pressure then over 140/90, and if it's present on 3 different occasions, in other words, you measure it on 3 separate occasions to show that it's greater than 140/90, then that's the definition of high blood pressure. By the way, it has to be taken seated. You have to be seated in an armchair. Traditionally, it's said that it has to have arms on the chair, and you have to be seated for 5 minutes resting before you take the blood pressure. So somebody who rushes into your office after just getting out of work and wants their blood pressure taken, not a good way to take the blood pressure. Seated, arms rested for 5 minutes, and then take the blood pressure. That's the standard.
It's also important, I've found that a lot of my patients, if they're a little nervous, so they're talking to me while I'm taking their blood pressure will be higher than if they just be quiet for a little bit and really totally rest and relax that arm. And of course, you and I know that it's important to have the right size of cuff, but for them, that's not necessarily the big thing. But yeah, you're right, it has to be. And I've also learned it has to be repetitive. Unfortunately, over the years, I've seen patients who had their blood pressure up one time and somebody put them on medicine, and then you're never sure, well, is it really elevated, or is it just that it was that one time for whatever reason?
Yeah, so that 5 minutes that it takes for the nurse to check you in and me to come in might be the important time for you to just sit there quietly and make sure your blood pressure is well controlled. Yeah, and so it is true. So what I try to do in my practice is, and I know that you would likely do the same thing, is that the nurse takes the blood pressure and then I come in and try to confirm the pressure, but I also sit and talk with the patient for a little while and talk them down, if you will, because they have usually a list and all sorts of other things that they want to go over with me. And what I'll try to do in that situation is talk them down for a while. And then when they look like they're calm, or if they're not calm yet, I'll look in their eyes, or I'll do something else. And I'll try to see if we can get the blood pressure to settle down with a little bit of time. If it doesn't, then that perhaps is significant.
And those are the ones we usually have maybe come back every day for a few days, or check a few more times and make sure that it is staying down. I think that's really important. We talked a little bit about hypertension and what's normal and what's abnormal. My experience has been that very few of our patients have hypertension that can actually be treated once and go away. In other words, if they really have hypertension or high blood pressure, it's probably a lifelong pattern. But let's talk about for just a bit those few patients that sometimes have a narrowing of an artery or a growth somewhere in their system that when we take care of that problem, their blood pressure goes back to normal and stays that way.
So you're absolutely right. Yeah, 90% of the patients who walk into your and my office are going to have what we call essential hypertension, which means, unfortunately, we don't have a cause. It's probably genetic, could be certain environmental things, for example, salt intake. It can also be other drugs that you may be taking that's causing it. So, but most of the time, the high blood pressure is essential. Now, 5 to 10% of the time, there are secondary causes. And so those kinds of causes are relatively rare. They can be related to, as you mentioned, blockages in the kidney artery. There are certain little glands that sit on top of your kidneys called adrenal glands that can grow little tumors that cause high blood pressure. You can also grow tumors elsewhere that can cause high blood pressure. So yes, there are some relatively rare forms of high blood pressure. By the way, the one that we like to pick on medical students about is licorice. So that if you happen, now it's illegal to sell a licorice that contains this particular compound in the United States, but you can import it from Europe and elsewhere where it's called glycerinic acid. And don't ask me to spell it, but glycerinic acid is forbidden to be used in licorice that's made domestically. But if you happen to be a connoisseur of international licorice, there are certain black licorices that actually have this compound in it that raises your blood pressure. And so one of the fancy questions that we teach the medical students to ask about is, where do you get your licorice?
It's interesting, in 30-some years of practice, I actually did have one patient who said, oh yeah, I love real black licorice. Just you relieve most of our people watching because red licorice doesn't count.
That's right.
And that's what most people like is the red licorice. So I think it's important to note that. As we've talked about that, let's talk a little bit about the dietary things and the things, you know, everybody today wants to do things without medicine. So if you have essential hypertension, or it looks like you may have essential hypertension, let's talk a little bit about not only the licorice, but the foods that we eat, what we drink, exercise, those kind of things. Mm-hmm. You would think that obesity would be a causative factor. At least in my experience, big people don't necessarily have hypertension. Some of my little people or very thin people actually have hypertension. So weight in its own right isn't 100% likely to predict it, but there are some other things in the diet. So let's talk about that a little bit.
All right, absolutely. So that you're right that there are environmental things that we do to ourselves that make the blood pressure go up. For example, high salt diets. If I take and increase the amount of salt intake in my diet, my blood pressure will go up anywhere from about 6 to 10 millimeters of mercury. Contrast that with if I lower my salt intake, I can actually get 6 to 10 millimeters of mercury fall in my blood pressure as a result of that. And the diet that we commonly recommend is called the DASH diet. The DASH diet stands for Dietary Approaches to Stop Hypertension, or DASH. It's all capital letters. It's been studied by the National Institutes of Health, and you'll see a website a little bit later in the program that talks about this. But it's been studied by the National Institutes of Health since the late 90s, and it can actually result in a lowering of the blood pressure by 6 to 10 millimeters of mercury by itself. It involves a low-salt diet, increases in the amount of fruit and vegetables in the diet, and the use of low-fat dairy. For example, cottage cheese, skim milk, low-fat cheese, those kinds of things, where you use dairy products that are very, very low in fat in order to avoid the calories, but they have high calcium. In other words, calcium intake. Now, that's not to say calcium pills lower blood pressure. It is low-fat dairy that contains calcium that lowers blood pressure. Second point, you mentioned exercise. Absolutely. It's been shown that 150 minutes of exercise per week, and in conjunction with about 10 minutes of light resistance activities, usually weights or resistance kinds of machines or those kinds of things that you might get on, 10 minutes twice a week. So in other words, 150 minutes of we call it physical activity outside of activities of daily living. In other words, getting up in the morning, walking out to the mailbox, those kind of things don't count. It's got to be some purposeful activity for 150 minutes. That lowers the blood pressure between 2 and 4 millimeters of mercury by itself. You don't need to do anything else. Weight loss, you mentioned obesity. Well, it is true that it's been difficult to show that obesity by itself is an absolute risk factor for high blood pressure. But what you can show also, though, is that anyone who is either overweight or obese who does have high blood pressure and loses 10 pounds, all you need is 10 pounds. And what you'll see is the blood pressure will go down about 10 millimeters of mercury for that first 10 pounds of weight loss. Now, to lose 20 pounds doesn't mean your blood pressure goes down 20 millimeters. 10 pounds of weight loss will get it down 10 pounds, get it down 10 millimeters, and then as the weight loss continues, there may be a slight decrease, but it's that first 10 pounds of weight loss that results in the most dramatic improvements in your blood pressure control. Eating that healthy diet, exercising on a regular basis, and trying to be as prudent about your calorie and weight as you can be, getting your weight down. Finally, don't smoke. Okay, smoking, bad, raises your blood pressure. Turns out alcohol raises your blood pressure. So that if you are a woman and you drink more than 1 drink per day, that is actually causes high blood pressure. So 2 drinks a day for a woman is enough to actually initiate high blood pressure. Same thing occurs with men, but men get 1 extra drink. So in other words, they get 2 drinks. If they drink 3 or more drinks per day, it actually becomes a hypertensive agent. So another little question I ask my medical students, what's the most common cause of reversible hypertension in the United States today? And the answer is alcoholism.
I had a patient one time who we could not seem to get his blood pressure under control, and we worked and worked at it, and finally admitted to me that he had a substance abuse problem with alcohol, and he drank too much. And when he quit drinking about 25 years ago, his blood pressure went down to normal, and he's still not on medicine 25 years later.
Most common cause of reversible hypertension today. And then finally, one other little trick that doesn't require drugs at least, but it does require something, is in those obese individuals that you mentioned, they are at higher risk for sleep apnea, disease where they have disordered sleep, they don't sleep very well, they have difficulties with their respiratory system at nighttime. In those patients who have untreated sleep apnea, who have obesity as a risk factor, if their sleep apnea gets treated, they will both decrease their blood pressure and lose weight. So that is the other non-pharmacologic treatment for high blood pressure, is to appropriately recognize and treat sleep apnea.
Okay, and some of us family doctors, we kind of raise blood pressure with the medicines we use. I know you kidney doctors are always very good about saying, oh, you better not put them on this, but we see a lot of things like sore joints and sore muscles, and so we need to just mention at least some of those medicines like the non-steroidal, which is that great big class of medicine, but the non-steroidals, and there are probably some other drugs that we need to be watching that unfortunately in some people, not everybody, but in some people they will raise your blood pressure.
Absolutely. Well, it turns out that you're right. One of my favorite drugs a few years ago was called Vioxx, which is now off of the market as a result of its complications. But a few years ago, every patient I saw with high blood pressure that was on Vioxx, all I had to do was stop the Vioxx and the blood pressure went away. Now, some of you won't recognize that medicine because it has been taken off the market by the FDA. But there are a number of others that are out there like that, and they are ibuprofen, Advil, Motrin, Aleve, naproxen, Toradol. So there's a number of those agents that are out there that we call non-steroidal agents. And what they do is they change people's characteristics. First of all, they wipe out the kidney's ability to protect itself. Second of all, they create a situation where people retain salt. So they're what we call sodium retentive. They retain salt that raises your blood pressure. Now, the other thing that they do is if you already have pre-existing high blood pressure and you're taking medications such as ACE inhibitors, I don't want to get too into the weeds here, but ACE inhibitors, ARBs, or diuretic agents, the non-steroidals take all three of those medications and make them useless. So that in somebody who has well-controlled high blood pressure for a while, and then all of a sudden their blood pressure comes out of control and they're taking one of those non-steroidals that I just mentioned, all you have to do is get them to stop that drug and their blood pressure comes back under control. Other drugs that I've found in my practice are nasal sprays and decongestants. Patients who use, and we have some people in this community who really like their nose sprays, and their nose sprays that are decongestants are hypertensive agents. In other words, it makes the blood pressure go up high. And so what we want to do is limit the use of those. If you're going to use nasal sprays for decongestants, it ought to be for not more than a few days, let's say 5 or 10 days at a time, and then there has to be a holiday in between. And that's what it says on the package insert.
Yeah, my experience has been that typically 4 or 5 days is at the most. But we also have an issue, of course, with just the decongestant medicines. Yeah, you have to go to the pharmacist and ask for Sudafed or some of these now because they can be used in other ways. But at the same time, some of those, in some of my patients, if they're on allergy medicine that contains a decongestant as well as an allergy medicine, some of those people, there goes their blood pressure.
Absolutely. So if you are taking a medication that has a D on the end of it, so Coricidin D, Claritin D, the D means increased blood pressure. Okay, now if you don't have hypertension, you can take D for short times, but we now have on the market those same antihistamines and decongestants that have HBP behind it. So the pharmaceutical industry have made it at least somewhat friendly that we at least put an HBP behind it. And if that cold remedy that you're taking has HBP behind it, then it doesn't have any of those bad things that I and you don't like.
Exactly. Well, we've talked about hypertension. We've talked about what it is, what the numbers are, how to monitor it, what to do with it, including home monitoring, which I think is a great idea. A lot of my patients do that. You know, they'll have a cuff like this. They don't have this kind anymore, but they'll have cuffs like this, and they'll monitor it at home. But unfortunately, for some of these patients, in spite of all of the things we've talked about, we've got to put them on medications. And there are several classes. I don't know if we need to go into specifics, but there are several classes, and you usually start, at least I start with one and see how they respond. And let's talk a little bit, maybe a little bit about the classes of drugs and a little bit about the treatment and the need for follow-up.
Okay, so in our patients who have hypertension, we've now taken the blood pressure for at least 3 times. We know that the blood pressure is elevated. We then need to classify the stage of hypertension, okay, so the stage. And so what we do is stage it. If your blood pressure is between 140 and 160 on the top number, or between 90 and 100 on the top number, we call that stage 1 hypertension, okay? If you, in contrast, if you have higher blood pressures than that, in other words, your top number is over 160 or your bottom number is over 110, in that situation, we call that stage 2 hypertension, okay? For stage 1 hypertension, meaning between 140 and 160, what we want to do is we want to at least get them on one drug and get them under control. Diuretics are a favorite. That's what's recommended by the smart people out there that write guidelines is diuretics. Diuretics have their own set of problems with them, and so your physician may not choose a diuretic. Other ones that have been chosen in the past but have now fallen out of favor are beta blockers, which are things that help control your heartbeat. ACE inhibitors and ARBs that I mentioned earlier are agents that can be used by themselves, but they don't work very well unless you stay on a low salt diet. So you got to start out with that salt restriction first before you go on those agents. And then we have a number of other agents that we can use. Now, contrast that with stage 2 hypertension. Stage 2 hypertension usually requires 2 drugs to control. So if your doctor says you want to be on 2 drugs, you're going to be asking them questions about that. But again, that's the standard of care. If they have stage 2 hypertension, they're going to be on 2 drugs. If they get to 3 drugs or more and their blood pressure still isn't controlled, we call that resistant hypertension. And in that situation, you may want to be looking for some of those secondary causes that we talked about, or you may want to refer them to me where we do specialty hypertension. And those are the kind of things we do.
Well, and that's the type of thing that I've seen, is that for some patients, as we talked about, there's side effects to these drugs. And so some of the drugs that you think may work well, you push them, if you push them higher, you actually don't improve their blood pressure control. So sometimes it does really work better to use 2 drugs at maybe lower doses, but the 2 drugs in 2 different ways work to help control the blood pressure. So those are important things. And as we talked about before, once we've diagnosed hypertension, you can anticipate, sorry, but it's going to be the rest of your life. I just tell my patients it's going to be a longer life, though, if you take the medicines.
Yeah, we hope so.
Thank you again, Dr. Spry.
Thank you.
Well, this has been Talks with Docs, a service of the Lancaster County Medical Society. Today, my guest has been Dr. Les Spry, a nephrologist here in Lincoln, Nebraska, as we've talked about hypertension, its dangers, what it can mean, how to treat it, how to prevent it, and many of those important things that patients here need to know about their blood pressure. Just tell my patients.